Imagine for a second that you're not sitting in this room in Oxford, where a health clinic might be around the corner or a short bike ride away. But instead, imagine that you're in an isolated rainforest village and you wake up one morning with a fever. And you panic because that fever is probably malaria. And you know that in order to get the life-saving treatment that you need, you have to take your feverish, frail body, put it in a canoe, row across a river, and then hike for up to 2 days to the nearest clinic. Now, it's an impossible situation, but it's not just a situation of one person in one isolated village. Actually, over 1 billion people in the world go their entire lives without ever seeing a health worker. And the WHO estimates that we're currently short about 7.2 million health workers, and that this disparity is growing. By 2035, it's actually set to double. And this absolute shortage of health workers actually masks a much more devastating geographic distribution. What we see is, for example, sub-Saharan Africa has 1/4 of the world's burden of disease, but only 3% of the world's health workers. And similarly, those health workers in those countries are usually in cities far out of reach of that person in that remote village. And so basically what we can conclude from this is that the standard solutions to healthcare crises, training more doctors, building more clinics, are necessary, but they're not sufficient. So far, doctors and clinics have conspicuously failed to reach those people living in the most remote communities. And so if we're really serious about universal healthcare coverage, what we need is a universal healthcare delivery mechanism. And my research is about finding new opportunity in what's actually kind of an old idea. Community health workers, not a new thing. They've been around since the 1970s, and were actually touted at the 1978 Primary Healthcare Conference in Alma-Ata as a great way to deliver healthcare, as a way of taking primary healthcare to people in low resource settings. And we've actually seen a number of trials that community health workers, a number of randomized control trials have shown that community health workers are efficacious at delivering health interventions as diverse as birth control injections, curing malaria, diarrhea, pneumonia, providing counseling and chronic care for HIV patients, and that ultimately community health workers have the potential to reduce child morbidity, child mortality, and neonatal mortality when compared to usual care. And so this sounds excellent, but what we've seen subsequently is that in a lot of ethnographies and cross-sectional surveys of actual national programs, not just community health workers in an experiment, in a trial, but actual national community health worker programs, we've seen that often these programs are plagued by absenteeism. The CHWs have substandard health knowledge, they have poor diagnostic capabilities, and usually the reporting on their health activities is not so good. And so what we see is these large-scale programs often fail to move the needle on morbidity and mortality indicators in the way that we would expect, in the way that we would hope. And so basically what I'm saying is that community health workers, at least in their conventional form, often fail. But it's not their fault. Too many health systems underinvest in community health workers, and so they underperform, particularly, unfortunately, in the areas where they're needed most. So let me explain. Basically, the status quo, I guess you could say, for training a community health worker, like Mark said in that photo, is that a community health, is that a village chief would pick a member of the community without any regards to their qualifications. They'd send them away for a couple days of non-assessed training by, USAID or someone like that, and then that person comes back to their village unequipped, unsupervised, and unpaid, and is then supposed to provide healthcare for the entire village. Imagine if you ran a factory like that. You wouldn't get any results. Because we treat health workers like amateurs, they perform like amateurs, and as a result, the health of their people suffers. Those who never had healthcare ultimately never get it. And so what we're working on is doing things differently. Not with medical innovation like Anne, but with, I guess you could say, entrepreneurial creativity. I'm working with a group called Last Mile Health, that is a Liberian NGO that works with the Ministry of Health in Liberia to figure out basically how to develop a workforce to deliver healthcare in the world's most remote villages. And what we do is we look at the 5 processes basically that are needed to support health workers: recruitment, training, supervision, equipment, incentives, and how to make each of those better. And so through longitudinal data collection and through randomized field experiments, we're figuring out what type of package, what type of optimized package actually is required so these health workers can have the health impact that we know they can have, but so far have not been able to have because of lack of support, basically. And so far, the replicable model that's been developed in Liberia has had pretty encouraging results. I'm going to get into a lot more of them when I have 3 extra minutes. But suffice to say that in Konobo district, which is a really remote district in the southeast of Liberia near the border of Cote d'Ivoire, we now see that 98% of women, for example, get their prenatal care in their village. 97% of children can now be treated at their doorstep, and that these results were actually robust during the Ebola crisis, which is a particularly interesting thing, again, that I'll talk more about. But basically signals that if you make these upfront investments in strong community health infrastructure, if you give people care on their doorstep where it matters most, from people that will actually, unlike doctors, stay in those places for the long term, you can have transformative health effects. So basically, to conclude, illness is universal. Access to care is not. But nobody should have to die because they live too far from a doctor. And we have some interesting research that basically suggests that if you give community health workers the tools they need to succeed and hold them to rigorous performance standards along the way, then nobody has to.